laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute the device. For the DURB board member, please reserve your questions to the end of the presentation or may ask in the Google Hangout meeting chat. And any public comment a COI must be on file. Please send an email to medicaidpharmacyutah.gov. The attendees that are not members of the DURB board, would you please enter your contact information on the Google Meet chat or email medicaidpharmacy@utah.gov. And please use the chat on the right if needed. And provide normative feedback after the meeting to help us improve our process moving forward. Thank you and welcome to the Utah Medicaid meeting, the DURB board of April. Dr. Keenan, I will leave the rest to you.
All right, thank you, Noon. I think we're probably ready to go. We've got a quorum. So we'll call this meeting to order of the Utah DURB board. Why don't we start? I'm assuming that Noon covered any housekeeping things that we have. So let's move ahead to review and approval of the minutes. Everybody should have received a copy of the minutes. Are there any questions or changes that need to be made to the minutes? Okay, that was probably 8 seconds. All right. Hearing none, do we have a motion to approve?
Just a reminder that the Google Hangout might have muted you, so you might want to unmute if you want to speak to the group.
Yeah, this is Kyle. I'm happy to move that we approve the minutes as written.
Thanks, Kyle.
Yep.
I will second. All in favor?
Aye.
Aye.
Okay, hearing no nays, the minutes have been approved unanimously, shall we say. All right. Noon, it looks like we do have an update on the antipsychotic edits. So we'll turn that back over to you guys.
Okay, thank you. So yes, to better align with Florida and Texas guideline, with these antipsychotic only pertaining to children 17 years old and younger, we are currently removing the prior authorization required for concurrent use of antipsychotic in children 18 years and up. Just a couple of years ago, we implemented that for 18 years and up, and this is no longer apply. And that is the updated on our side for antipsychotic use in children. You are on mute, Eric.
At least you can see my lips moving. So you're proposing that we remove that edit. Do we need to take a vote on that?
No, that is open to access. So we are doing that.
Okay, perfect. Brian, I think you've got an update on the P&T committee.
Yeah. So in May, the P&T committee will be reviewing colony stimulating factors. And we will also have our annual presentation from our ACO partners.
Great. Thank you. So with that, we'll turn it over to the University of Utah for treating low back pain.
Okay, I will go ahead and present the slides. Okay, hopefully everyone can see those slides now. We'll go ahead and get started. Good morning, everyone. The objective of the report reviewed today was to summarize recent U.S. guideline recommendations for the non-invasive treatments for nonspecific low back pain with or without radiculopathy. The symptom of low back pain, or LBP, may be associated with many conditions, such as degenerative disc disease, sciatica, and osteoarthritis. Approximately 90% of cases are diagnosed as nonspecific back pain. In the US, LBP is one of the most common adult diagnoses, with up to 84% of adults experiencing it at some point during their lifetime. The prevalence and age of onset depends on the cause of the LBP. LBP is slightly more common in women than in men. LBP symptom reoccurrence is common, with 24 to 80% experiencing a return of symptoms within a year of recovery. LBP is categorized by duration of symptoms as acute, subacute, or chronic, with chronic LBP being symptoms persisting for more than 12 weeks. LBP may present with radiculopathy, which is a term used to describe a range of symptoms, including pain that results from spinal nerve root impingement. LBP with radiculopathy presents as sensory loss, tingling, or motor loss extending into one or both legs. Typically, LBP is self-limiting, with resolution of symptoms within 2 to 6 weeks of initial onset, but symptoms may persist longer. Due to the self-limited nature, many patients do not seek medical treatment, which may impact the persistence of symptoms. Other factors, also known as yellow flags, that impact chronicity include psychosocial and employment factors. The target population of the recent U.S. guidelines published in the last 5 years included adults 18 years of age and older with nonspecific LBP with or without radiculopathy, except the 2020 North American Spine Society, or NASS guideline, which only included non-radicular pain. Each guideline contained recommendations for pharmacologic and non-pharmacologic management for acute, subacute, and chronic nonspecific LBP, except for the Institute for Clinical Symptoms Improvement, or ICSI, which focused only on acute and subacute LBP. To supplement the U.S. guideline recommendations, guidelines from other countries such as Canada and the United Kingdom were included in the report. Given the vast array of possible causes of LBP symptoms, guidelines recommend a triage approach to diagnosing LBP regardless of symptom duration. A detailed history and physical examination are recommended to identify neurologic deficits such as radiculopathy and serious pathological causes of LBP that would require additional diagnostic evaluation and/or referral. Signs and symptoms that may be indicative of a serious pathological condition are referred to as red flags. The history assessment should include evaluation for the presence of yellow flags. Generally, the use of radiographic imaging to diagnose LBP with or without radiculopathy should be reserved for patients presenting with red flags. Providers should characterize the patient's pain, such as by location and intensity. Imaging may be warranted in patients with serious or worsening pain or neurologic deficits, or when symptoms persist for more than 12 weeks. A variety of non-pharmacologic and pharmacologic therapies are utilized for acute, subacute, and chronic nonspecific LBP with or without radiculopathy. Radicular pain is treated the same as nonspecific LBP. However, steroid injections, which were not specifically reviewed, is an interventional option for patients with radicular pain. Therapies for which a recommendation was not provided for or against among the U.S. guidelines include anti-epileptics, including gabapentinoids and lidocaine patches. Of note, NICE recommends not to offer gabapentinoids due to a lack of supporting evidence and the greater risk of harm from adverse effects, but that a shared decision-making approach regarding whether to continue treatment should be employed for those already on gabapentinoids. Education on self-care is recommended for all patients with nonspecific LBP with or without radiculopathy. Heat is recommended for transient pain relief in patients with acute or subacute nonspecific LBP. Spinal manipulation is recommended for acute, subacute, and chronic nonspecific LBP, particularly as an early intervention for acute conditions. Guidelines are conflicting about the therapeutic utility of acupuncture depending on symptom duration, which may be due to the substantial heterogeneity of the evidence. American College of Physicians, or ACP, recommends acupuncture for acute, subacute, and chronic nonspecific LBP. ICSI recommends acupuncture only for subacute nonspecific LBP, and the Veterans Affairs Department of Defense, or VA DoD, and NAS guidelines recommend acupuncture only for chronic nonspecific LBP. Guidelines describe studies that suggest benefits of massage for pain reduction in patients with subacute or chronic nonspecific LBP, but rarely provide recommendations on its use. Exercise therapy, such as clinician-directed programs, Tai Chi and Pilates, and psychological therapies, such as cognitive behavioral therapy, are generally recommended for the management of chronic nonspecific LBP with or without radiculopathy. However, in addition to chronic LBP, the 2022 VA DoD guideline recommends clinician-directed programs for patients with acute or subacute LBP. A multidisciplinary biopsychosocial rehabilitation approach incorporating physical and behavioral or psychological interventions to manage symptoms is recommended for patients with more severe or complicated chronic nonspecific LBP. NAS recommends topical capsaicin for short-term use for the treatment of nonspecific LBP. Other guidelines either do not address topical therapies or do not make recommendations about their use due to insufficient evidence. U.S. guidelines recommend oral nonsteroidal anti-inflammatory drugs, or NSAIDs, for short-term pain management in patients with acute, subacute, and chronic nonspecific LBP. Except NAS, most guidelines favor cyclooxygenase 2 selective NSAIDs over conventional NSAIDs. NAS favors non-selective NSAIDs due to inconclusive evidence for the use of selective NSAIDs. Due to consistent evidence demonstrating a lack of efficacy with acetaminophen, concerns of harm predominates guideline decisions, resulting in conflicting recommendations in acute nonspecific LBP. ACP no longer recommends acetaminophen for acute nonspecific LVP due to a lack of established superiority versus placebo. In addition, the updated 2022 VA DoD guideline no longer recommends acetaminophen for nonspecific LVP. In contrast, authors of the ICSI guideline view that acetaminophen poses a very low risk of harm, so despite failing to demonstrate superiority over placebo, authors recommend a trial of acetaminophen for patients with acute and subacute nonspecific LBP. Guidelines tend to recommend non-benzodiazepine skeletal muscle relaxants such as cyclobenzaprine or tizanidine for short-term use in acute or subacute nonspecific LBP. NAS and NICE recommend against antidepressants for nonspecific LBP. Other guidelines, such as the VA DoD and ACP, recommend consideration of duloxetine, a serotonin norepinephrine reuptake inhibitor, for chronic nonspecific LBP. U.S. guidelines only recommend a short course of opioids as a last-line option in most LBP conditions, especially chronic nonspecific LBP, with inadequate relief from other medications and only when therapeutic benefits outweigh the risks. Of note, the updated 2022 VA DoD guideline recommends against the use of opioids for patients with chronic nonspecific LBP. Some guidelines provide a separate recommendation for tramadol, perhaps due to its slightly different mechanism of action by inhibiting serotonin and norepinephrine reuptake. ACP recommends tramadol as a second-line agent for chronic nonspecific LBP. ICSI recommends a trial of short-acting opioids in patients with severe acute pain that has not responded to non-opioids. In such cases, clinicians should use the lowest effective dose for 3 days or fewer. Table 11 of the report provides a full list of warnings and precautions for the agents used to treat nonspecific LBP with or without radiculopathy. Here I'll highlight black box warnings or some drug class effects. NSAIDs, regardless of selectivity, carry a black box warning for increased risk of cerebrovascular events, including myocardial infarction and stroke, and gastrointestinal events such as bleeding, ulceration, and perforation. Acetaminophen has the potential to cause rare but serious, potentially fatal skin reactions such as Stevens-Johnson syndrome. High doses of acetaminophen exceeding 4 grams per day can result in hepatic failure and death due to liver injury. Duloxetine carries a black box warning for increased risk of suicidality, including emergent thoughts and behaviors among children, adolescents, and young adults. Warnings and precautions differ between skeletal muscle relaxants, with some agents having the potential to cause anticholinergic side effects or dysrhythmias, such as cyclobenzaprine, while the majority tend to increase the risk of CNS depression, especially with concomitant use of other CNS depressants, such as alcohol and opioids. Opioids carry a black box warning for the increased risk of addiction, abuse, and misuse, increased risk of fatal respiratory depression and overdose with accidental consumption, the possibility for neonatal opioid withdrawal syndrome, and the potential for drug-drug interactions. Significant respiratory depression, which may result in respiratory arrest and death, has occurred with opioid use. Drug-drug interactions, including those due to drug metabolism or concurrent CNS depressant use, increase these risks. Non-pharmacologic interventions, such as education on self-care, are preferred as the initial approach for nonspecific LBP due to low inherent risks. Usually, pharmacologic treatment is reserved for patients presenting with more severe symptoms that fail to adequately respond to non-pharmacologic interventions. Generally, oral NSAIDs are considered the first-line pharmacologic option for the treatment of nonspecific LBP with or without radiculopathy. Several U.S. guidelines do not provide a recommendation for acetaminophen since it appears similar to placebo for pain reduction in LBP, but some experts may consider it as an option for trial due to its low risks relative to other medications. Typically, non-benzodiazepine skeletal muscle relaxants are reserved as second-line pharmacologic agents for short-term use in the management of acute or subacute nonspecific LBP when therapy with NSAIDs or acetaminophen has failed. However, ACP recommends skeletal muscle relaxants as first-line agents for acute or subacute nonspecific LBP, with the decision to select an NSAID or muscle relaxant based on patient-specific factors. Although the VA-DoD guideline does not explicitly state the place in therapy for duloxetine, ACP lists it as a second-line agent for individuals with chronic nonspecific LBP that previously failed non-pharmacologic interventions and NSAIDs. As previously mentioned, tramadol is also recommended as a second-line agent for the treatment of chronic nonspecific LBP, whereas other opioids are reserved as last-line agents. Guidelines tend to discourage the use of opioids, especially for acute or subacute nonspecific LBP. Due to the risk of significant adverse events generally outweighing the benefits, it is recommended that opioid therapy should be prescribed for the shortest needed duration at the lowest effective dose. This concludes the presentation. Please let me know if you have any questions. Thank you for your time and attention.
All right, let's open it up to the board. Are there any questions?
I don't have questions, but I have a couple comments. Low back pain obviously is an enormous topic, and you've digested a huge number of guidelines, and I think it would be apparent to anybody that we're still in a stage in pain medicine where we have a lot of missing evidence and areas of conflicting evidence. But I want to make a couple of comments, and I'm going to speak from a few perspectives. One, I'm a neurologist. Two, I'm a pain medicine expert. And three, I've been serving as the national subject matter expert for the Veterans Health Administration for massage therapy. I have some perspective that may, in some respects, not have the evidence behind it, but we're accumulating a lot of experience, particularly on the VA side. So my first comment is I have difficulty with the term non-specific back pain. And I think that reflects that the majority of back pain is, presents in primary care. And one of the things that is important to say, for any condition to be well managed, it needs to be properly diagnosed and understood. So where we have sometimes acute conditions becoming chronic is because we don't get the right treatment going in the first place, and also the research isn't done properly in pain a lot because conditions are assorted and mixed up, right? So we get this kind of loss of specificity of effect in the studies because we have a lot of different conditions mixed up together, and that's been one of my problems with pain research over the years. So non-specific back pain, for me as a pain specialist, there is no non-specific back pain. If I see somebody, I make a diagnosis, but I understand that's not the world at large. Number 2 point about back pain, and I think this is also important for the clinical picture, is we do say back pain with or without radiculopathy, which means leg pain. And when somebody has leg pain with back pain, and that's maybe radicular, meaning it's coming from the nerve root. But this is really the point I want to make from the perspective of a massage therapist is sometimes referred pain is not radicular pain, meaning it's not coming from a nerve. It can be coming from soft tissue structures. And one of the things that hasn't really been well studied yet is the proper application of massage therapy. So if you properly diagnose myofascial pain and you treat it effectively with massage therapy, then you can relieve that referred pain, which is non-radicular referred pain. So a patient might have back pain and leg pain that's not radicular, and that's all myofascial, which is part of the reason why people are calling it non-specific, because we don't have a positive MRI. And again, one of my biggest frustrations over the years of my career is that physicians aren't trained to do manual diagnoses. Most of what I learned about the soft tissues, I learned as a massage therapist before I became a physician. And we have, some of that recognition of what goes on in the soft tissues in our DO colleagues who learn that in osteopathic school, but even many DOs aren't practicing soft tissue manipulation anymore. So there's this big gap, and I hope you don't mind my editorializing a minute about all of this, because I think it's really important for the understanding of what's going on in the world of pain, particularly back pain now. So where I think we really still outside the VA missing a big boat is that we've got this gap of what most pain is in the back is coming from soft tissues, and the average clinician, I would say, doesn't know how to examine that or diagnose that, and then winds up looking for medications to treat that. Even though self-care is recommended, and I am all for that, also my clinical colleagues don't know how to recommend that self-care either. Although we're getting better, we're getting better. The other point I would make is that as those pains become chronic, as we've learned, and this is from the perspective of neurology, we have these tools now where we can see with functional MRI what is happening in the brain. And this has been very exciting for me as a pain specialist, because we know then that chronic pain becomes a function of brain circuitry. And so what we what we're able to explain to patients now is that, where you feel the pain is not where you're experiencing the pain, right? You feel it in your knee or your back, but these are circuits, and circuits can be remodeled. And so in addition to self-care and all the things that you've listed there, again, this is something that we're doing in the VA, our Office of Patient-Centered Care and Cultural Transformation. I'm assigned to the Integrative Health Coordinating Center. All the things that we do, including CBT for chronic pain, meditation, Tai Chi, some of the other things you mentioned, those are intended to remodel the pain circuits. So one can be essentially cured, if you will, of chronic pain with regular practice of these techniques. And so we can treat the source of the pain, we can give medications to alleviate pain, but we also want to encourage patients and teach them how to engage with these practices to literally remodel their pain circuits. And I think any comprehensive approach to pain care has to have all of these has to have all of these modalities. I guess the last comment I wanted to make was, maybe it's the last one. No, a couple, and then I have a question. Pain severity doesn't always correlate with seriousness of the condition, right? So you might have a patient that literally immobilized on the floor, unable to move, calling 911, and with a severe back pain. And that is something that is a common term for that is acute locked back, and that turns out to be a muscle spasm, and that is all it is, and has nothing to do with anything serious pathology other than that, but the pain is severe and immobilizing. And you might have other patients who perk along with a low-grade osteomyelitis in the vertebra, and that's not causing much pain at all. And that turns out to be a life-threatening condition because they're seeding their cardiac valve. So pain is, I'll try not to go on and on, but it is can be a very complex diagnostic challenge at times, but there are a few things that I think are essential for clinicians to know that aren't well taught still, right? And so what we try to teach patients, severity, yes, I understand you're in severe pain, but that is not necessarily make this a life-threatening and serious condition. And that goes into the psychology of pain, which is critical in taking care of patients, as is in the report. I didn't see that we talked about in the non-pharmacologic care here, physical therapy per se and other procedural approaches. And I wasn't sure if that was just, deliberately meant to be in another, part of care, because we know those are generally part of comprehensive pain care to refer patients for those things. And when massage therapy is given a lot of times in the medical setting, it may be given in a chiropractic office. It may be, offered again by DOs or physical therapists. We haven't fully integrated massage therapists into the health system outside of the VA where we have. So, I wondered what was, if there was a reason not to include those, those other disciplines, like interventional pain management and physical therapy in the report. And if anybody has any questions or comments on what I've said, I'll stop there. But I think that was my question. And thanks. That's a very well synthesized report on a lot of guidelines and things. So thank you so much for indulging me.
Yeah, thank you for your comments. That was really, really insightful. I appreciate it. Just to address your question really quickly, For our literature search, we mainly focused on guidelines that had pharmacologic treatment recommendations. And then we additionally looked at non-pharmacologic treatment recommendations, but there are specific guidelines, like you said, that focus on physical therapy. So to supplement some of the information provided, we did include, I believe it was the 2020 Academy of Orthopedic Physical Therapy guideline, just to supplement the information, because they do provide additional recommendations or recommendations that may differ from the other guidelines.
I have a question, please. May I go ahead?
Yeah, of course.
Okay. So my question is, what percentage is the unspecific, with respect to the total? That I didn't hear.
Yeah, so that was about 90% of the cases are non-specific, and so which was quite a bit. Yeah. So and that we just kind of is termed as back pain that's not associated with a specific cause, such as degenerative disc disease, sciatica, osteoarthritis, and and the list could go on and on about those other low back pain conditions.
See, what I was hoping was that somehow you could find out to subdivide the non-specific into some categories that are most prevalent, and then perhaps in future we could have better guidelines. That's it. Thank you.
Thank you.
Well, Kumar, this is the problem with the diagnosis in the presentation, right? And what gets into the records. I don't believe it is non-specific, meaning there's no cause of it. I think what happens is the evaluation doesn't get captured properly, and these particular. Okay, let me say this. This isn't easy to hear, but our discs start degenerating at age 25.
Okay.
So any X-ray you take of anybody is going to show after age 25 in the spine is going to show some degenerative change. That doesn't necessarily mean that that's causing the pain, right? It takes some skill to evaluate a patient, which includes being able to evaluate their soft tissues and also do certain mechanical exams to know, is this the facet joint? Is this loading? Is this the soft tissues? Do they have a radicular component? Is this myofascial referred pain? Is this referred pain from inside the pelvis? Is this the intestine? In a woman, is this the ovary? I mean, there's a lot of possibilities. And I think, non-specific back pain means the clinician isn't worried that this is a malignancy. And so they say, okay, go on, do this, because most of the time it's self-limited. And like all other pain, the first step clinician doesn't do a very detailed evaluation, and doesn't, like we've seen in other conditions we've evaluated, the diagnoses don't get into the records, right?
So how do we improve the training process, and how do we teach new doctors at the medical school? I mean, those are kind of things perhaps we can do.
About pain?
Yeah.
Well, you and I can go out and talk about that for about 10 hours. I absolutely agree with you. I think any recommendation that goes to advancing the cause of pain and pain treatment, number one is prevention.
Yes.
Because self-care here, in my concern, is it's after the fact. If we know that okay, I'll make one more editorial comment. The reason we all get low back pain, because the majority of us are going to have some pain in our lumbar area at some time in our life, is because we stood up on two legs, right? We evolved to stand up on two legs, and the lumbar spine was not made for that. So we'll talk to the engineer, okay?
Right.
We're standing on two legs. So these, so you're going to have some low back pain in your life. So we as primary care people, right? Self-care is a way of life. This is what the Office of Patient-Centered Care and Cultural Transformation is doing in the VA. We're teaching people to live healthy. Now, I, as a primary care doc in my early life, this is what we teach to begin with, right? Self-care to begin with means you do your core exercises as a way of life. And that's how you prevent pain. There's good studies out of Scandinavia that show you can do yard work and housework, but if you don't do your therapeutic exercises to protect your back, you're not going to be able to do those things without back pain. So we need to teach people prevention. That's what I'm harping on here, right? Back pain is about prevention because we're all going to get it.
Right.
And if we wind up with somebody who says, here, take these muscle relaxants, and when they don't work, here, take these opioids, then we wind up in the pickle jar we're in. So prevention is the important thing. And prevention is about healthy eating and exercise and so on. And you all know this. I'm just saying, after the fact of self-care means now you have to go into prevention mode permanently. And that's, but our primary care isn't set up for that either, I'm afraid. So it's not only diagnosing pain after, it's preventing to begin with. And now we've got, neck pain from all the other stuff we're doing, right? So it's all part of the same thing. And again, I don't mean to go on and on about it, but we've got a big public health problem called pain. That's largely associated with lifestyle, the same way heart diseases and diabetes, right?
Yes, thank you. Appreciate it.
Great. Thank you, Dr. Weinstein and Monet. Thank you for a great presentation. And I think we've identified an area I think we've known for a long time that one of the single biggest drivers of overall cost is low back pain. And I think, we're fortunate that we are now starting to see low cost imaging in our market here in Utah that takes the price of an MRI down significantly. So, potentially providing more access, I think, for those diagnoses and help in terms of driving appropriate treatment, also in terms of accessibility. So there's lots of education efforts underway in terms of low back pain and really how we move ahead with that. But I agree with Dr. Weinstein that there still is a significant amount of work that needs to be done. Noon, do we need to take any action today on this?
Eric, so we have a utilization data that we want to share with the board. We just would like to, Dr. Winston have shared her a professional opinion on this. We greatly appreciate it. And if we can, have some board opinion, that would be great, but no action needed.
Great, thank you.
So this is our utilization for low back pain and opioid. This is the look back periods of 12 months from March of 2021 to March of 2022. The query was on looking at the ICD-10 medical claim and any opioid claim that has happened within 2 weeks of that medical ICD-10 claims. For the total number of fee-for-service, we have 1,000 of 1,400 patient fee-for-service, and ACO we have 4,200 patients for ACO. And number of patients has opioid less than 90 MME within those fee-for-service have 1,357 patients versus ACO for 3,772. And also 100 of 66 patients on fee-for-service have opioid more than 90 MME, and ACO have 1,000 patients who is using more than 90 MME having low back pain. Within those 260 patient fee-for-service have been using these for more than 3 months. ACO is 873 patients, and 86 patients have been using opioid more than 6 months. ACO have 314 patients. And the most recent one is for February of 2022, when we're looking at the prior authorization review, 27 patients have MME more than 90 and don't have the cancer pain diagnosis. Of the 27 patients, 18 of them have the low back pain diagnosis, among with others diagnosed, accumulate for about 60% of our patients. And our current opioid policy is we require 7-day supply initial prescription for opioid naive patient. We don't allow opioid use for less than 18 years of age and who was pregnant. Only limit to 7-day supply for those patients. We require at least 7-day supply of short-acting opioid before any long-acting opioid, and we restricted the benzodiazepine and long-acting opioid. We limit to 90 MME and quantity limits as well. And to add on to Jen's comment in the chat, that right now we don't cover massage, but we also cover spinal stimulator, exercise, psychotherapy. We also don't cover acupuncture. If we can have the board maybe some insight into how we can better manage the low back pain, but no action needed.
Right. No, thank you, Noon. I think good information on the use of opioids. I can tell you that within the Select Health ACO population, the average morphine equivalence per day has come down drastically as the different additives have been put in place, and quite frankly, significantly lower than our other populations. So I do think that those actions have had an impact, and we continue to see that impact maintained. So I think that's a positive thing. I think the single biggest thing, perhaps in terms of low back pain, is just making sure patients have access to a provider, and as Dr. Weinstein said, one that is trained in diagnosing and understanding kind of low back pain and all the issues that go along with it. Other thoughts, comments?
Well, it's labor intensive. Somebody who's had chronic pain and been on medications for a while and needs to be changing lifestyle and accessing other non-pharmacologic cares. So I'm still working in, university system and VA system, and even on VA side where we're paying for acupuncture and chiropractic and massage therapy and cognitive behavioral therapy for pain and Tai Chi and yoga, paying for it and making it readily accessible even through telehealth. It's still a challenge to have people fully engage sometimes with these things. How do we do this in an arena where these non-pharmacologic cares that people are saying are valuable and needed they're not accessible? Number one point, Eric, you said the patient needs a provider. The patient needs a provider that's not only trained but has the time and is going to stay with the patient, meet with them monthly, coach them, and coordinate all these cares into the field where the services aren't being paid for. So I'm going to tell the patient, like I have one now, I believe is a Medicaid patient who has a horrible scoliotic spine and very severe back pain, who I believe is over 90 MME. And I'm trying to, wean her opioid down, but she has access to nothing. I mean, nothing. And so what do we do? I mean, it's a practical problem. I'm coaching her, and she does everything she can do on her own, but she has no access to non-pharmacologic cares otherwise. So I think these are system problems. And so, what can, this is really a serious question I'm asking. If Medicaid wants to say these are the cares that should be given, then what are we doing to provide them? I'm really being purposefully provocative here. What are we doing to provide them?
Yeah, and Noon and others, from the state, I guess. How much of what's covered in terms of, say, therapeutic massage, how much of that's driven by the state versus how much does that roll up under some kind of federal guideline?
Well, the federal, I mean, the federal, you mean federal Medicaid? See, because MT, you know, massage therapy is a billable service under Medicare, and it's been billable forever. 97124 is a billable procedure code, and, you know, anybody with the qualifications can bill MT. That's been there for a long time. It's just a matter of whether you say a patient can go to a licensed massage therapist. We're talking Utah. So massage therapy is a licensed health profession in Utah.
That was a great insight, Dr. Winston. And as we limited to not cover massage, but we also cover some sort of exercise and psychotherapy and also spinal stimulator on the medical side.
Right. So we'll send somebody for a, you know, 50,000 plus spinal stimulator without any, you know, okay.
Sure, Dr. Weinstein, I think we're all in agreement here, and we're lucky that we've got Jennifer on the line here, and she's raised her hand, and some of this is, I think, unfortunately outside our purview, but we'll turn the time over to Jennifer.
Yeah, I would just say I appreciate the dialogue, honestly, because I think it's something we've looked at evaluating even holistically with our ACO partners of how we address this and coverage policy to look at specific areas such as opioid use for low back pain, right? And so you asked, how do we cover massage therapy? And you all are familiar with I think you're familiar with our coverage policy process, but I'll just reiterate that to open a new service, we can evaluate it. Is it evidence-based? Is there literature to support use and all those types of things around standard of care? So first of all, Medicaid reimburses based off of, you know, evidence-based. We don't do investigational. We don't cover investigational services or things that are experimental. So we would evaluate that first of all on standards of care. And then, you know, we always go through this process of evaluating what other states are doing, including Medicare, actually, Dr. Weinstein. So your comments around coverage in Medicare are important in our evaluation of coverage policy. And then the third piece of this is, you know, fiscal impact. So if this is a big lift from a fiscal impact perspective, then there needs to be legislative funding for that service in order for us to cover it. And, you know, this goes through a couple of different methods. We could put in a building block request for it so that, you know, we directly can try to get coverage from the department perspective. We can get legislative support where, you know, someone like yourself could go speak with one of our representatives and seek coverage of this. I know, anyway, we have opportunities to do it that way. And then, you know, there's also our MAC committee, which takes suggestions, right? So we can look at bringing it through our MAC program where there are proposals. And this is where we've heard a lot of medication-related coverage requests, such as, you know, insulin, you know, different varieties with insulin coverage, for example, have been put through our MAC program. So, I mean, I know you're pushing some other ideas here through the chat, which we could certainly, you know, evaluate these things offline. But, you know, I would see this as being a new coverage, same as like acupuncture or something else would be, which would have a fiscal impact. So we would need some sort of legislative funding. While there may be evidence to support these modalities as a standard of care, opening the service would require some sort of, you know, funding for it. So how we would look at that, would that be a cost offset for other things? I mean, that's a research project we'd have to undertake. So I hope that probably a lot of familiar approach you've heard before, but for the purpose of this discussion, that's how we would get there.
Thank you. We appreciate that. Any other comments or approaches or things we would want to discuss today? All right, hearing none. it looks like for our next meeting, we have a review of Tezspire. Tezspire is a new biologic for severe asthma. And I actually look forward to that conversation. I think that it's interesting to watch as the biologics develop and we see the advances, but we're also stuck with the cost. So we'll look forward to that. And that would conclude our meeting this morning. If there are no other issues or discussion points we need to cover. And seeing none, Noon, did you have something?
Oh, no, I was about to say no.
Okay, perfect. Do we have a motion to adjourn?
Eric, I move we adjourn.
Second,
Thank you. We have a motion from Neil and a second from Dr. Weinstein. All in favor?
Aye.
Aye.
Okay, that sounds unanimous. We will see everybody next month. Thank you all.
Have a great day, everyone.